Hey guys, welcome back to All on Law. This is USMLE lecture, medical media lecture, and today we're gonna talk about Ice Bucket Challenge. No, we're gonna talk about why Ice Bucket Challenge is done. It's done for a disease. It's done to raise the money for a disease that's known as ALS. So most of us have done this challenge or accepted this challenge, or most of us have nominated the person, or most of us have watched the videos of this Ice Bucket Challenge on YouTube, but we don't know why it's done for. It's done to raise the money for ALS. What's the ALS? So today we're going to talk about the ALS, that's a amyotrophic lateral sclerosis. Unfortunately, we don't have a treatment, definitive treatment for this disease. That's why we're raising this money to extend the life of this patient suffering from this disease. Okay, so let's talk about this ALS, that is amyotrophic lateral sclerosis. Okay, amyotrophic lateral sclerosis. So it's also known as ALS, right? It was in 1869 a French scientist known as Jean-Martin Charcot who found this disease. He's a French neurologist. Okay, and it's also known as the Lou Gehrig's disease also. Okay, so now the amyotrophic lateral sclerosis, the name itself indicates amyotrophic is nothing but atrophy of the muscle fibers. Atrophy of the muscle fibers. Okay, and the lateral sclerosis is nothing but changes seen in the lateral column of the upper motor neuron axons. Okay, lateral column of upper motor neuron axons, and in these areas the degenerative changes takes place, and in these areas it's replaced by the fibrosis of the astrocytes known as a gliosis. So in a nutshell, I'm going to tell you the amyotrophic lateral sclerosis is a degenerative disease affecting both the systems of the motor neuron system, that's the upper motor neuron and the lower motor neuron, right? So this is what the disease is. Remember, in USMLE examination, if they gave the clinical features or signs of both the upper motor and the lower motor neurons, then think of ALS. So let's talk about the motor system. It affects the motor system, we say. Okay, so we have two. One is the upper motor neuron and the lower motor neuron. What's the upper motor neuron and the lower motor neuron? Regarding in detail of these what you call the motor system, we're going to talk in different video, but let me tell you briefly over here. The upper motor neuron is nothing but it actions from the cerebral cortex till spinal cord. Just remember, this is the basic I'm talking about. And the lower motor from the spinal cord till the muscles or the nerve ending, right? So this is what the upper motor and the lower motor is. So ALS affects both the upper motor and the lower motor, right guys? So let's talk about this, the epidemiology, the age, the sex. Okay, usually this disease can start from a teenage and up to 80 years of the life. Okay, and if you talk about the sex, the gender, it's a common in men than women, being the ratio 1.5 to 2 is to 1. But after the age of 40 to 60, or in some people 60 to 70 years, the ratio becomes equal. Means it equally affects both the sexes, the men and the women. Right guys? Okay. So let's talk about the another important point about this is the pathophysiology. Pathophysiology. The pathophysiology, the exact etiology, that is the cause of this disease, and the pathogenesis is not known, is unknown. Okay, right, guys? So the pathophysiology, the etiology is not known, but in some cases, that's the familial cases of this disease, ALS, they mapped what you call a locus on a chromosome 21 that's known as a gene. It's copper, zinc, superoxide, dismutase, right? So it's known as SOD1. So remember this important gene. This is located in what you call on chromosome 21 and known as copper zinc superoxide dismutase, right, guys? And the other causes could be a missense mutation. Wide variety of missense mutation have been identified, and that appear to what you call generate an adverse gain of function phenotype. If you talk about the most common missense mutation in this is, remember, A4V mutation. And the characteristic of this mutation, if the patient of ALS is due to A4V mutation, then they will have very rapid course of the disease. And another one characteristics is they don't have the upper motor neuron lesion. Okay, it could be very rarely seen in these patients. So a patient with ALS with A4V missense mutation will have the rapid course, and the upper motor neural lesion will be very rare. Okay, right, guys? Okay, the pathogenesis is what you call the recessive locus on chromosome 2. Okay, whereas the familial cases SOD1 is located on chromosome 21, right? So here on what you call the recessive locus on chromosome 2, and this codes for a protein known as asin, asin protein, and this protein has a similar structure to the protein involved in GT phase regulation. Okay, right, guys? Right? And another one thing about the pathogenesis of this disease is another one role has been identified is the glutamate toxicity and the protein nitration in the development of ALS pathology. Glutamate toxicity and protein nitration. Right? Okay, so we talked about this SOD gene, and remember the most common what you call the exact cause and the etiology of this disease is not known. And in a familial cases, they found SOD1 gene, that's a copper zinc superoxide dismutase on chromosome 21, and missense mutation A4V mutation. Okay, in these patients, they will have rapid course, and upper motor neuron signs will be rare. Okay, another one thing is a recessive locus has been identified on chromosome 2. This goes for asin protein, and this protein has a similar structure to the protein involved in GT phase regulation. And another one role has been identified, that's the glutamate toxicity and the protein nitration, okay, in the development of ALS pathology. So let's talk about the sign and symptoms. Clinical features or sign and symptoms. As we said, the patients will have both the sign and symptoms of upper motor neuron and the lower motor neuron. So if it affects the lower motor neuron, the first clinical manifestation they will have is the fasciculations. The fasciculations. Okay? And especially these fasciculations are seen in the tongue and limbs. And if we talk about the upper motor neuron signs, the first sign would be generally hyperreflexic and stiff. And reflexes may diminish due to the lower motor neuron involvement. So now it's very important to know what are the signs and the symptoms, what are the clinical, what you call signs of upper motor neuron lesion and the lower motor neuron lesion. Let me recall this. Okay, the findings of upper motor neuron lesion will be, tell me, it's a stiffness, that's known as a spasticity, and the tendon, as I said, they will be hyperreflexic. Okay, muscle spasm, right, presence of abnormal reflexes like Babinski, Shaddock's, Hoffman signs, right. And the signs that reflect what you call the lower motor neuron dysfunction is the twitching of the muscles. That's the fasciculation what we are talking about. And the fasciculation is typically seen on the tongue and the limbs. Muscle cramps, other signs of lower motor lesion like muscle cramps, reduction of the muscle bulk, that's an atrophy. That's why we call it as an amyotrophic lateral sclerosis. Okay, foot drop, depressed reflexes could be seen, but the prominent, what is hyperreflexic, are more common than the depressed reflexes. Okay, once the lower motor neuron dominates the upper motor neuron lesion, then you can see depressed reflexes, and ultimately they will have the breathing difficulties due to the lower motor neuron lesion, and it could be a fatal condition, right? So remember, the key finding in an involved limb is the combination of what the upper motor and the lower motor neuron lesions, dysfunctions. Okay, right guys? So as if means the patient will have a weak atrophic fasciculating muscle, right? That's due to what you call the lower motor neuron lesion, but they will have increased tone and hyperreflexia. That is due to the upper motor neuron lesion. Means we are seeing both the signs and the symptoms of motor neuron lesions, right guys? Now let's talk about another one important point, what is that is known as bulbar involvement. The bulbar involvement means it's going to affect the face, the mouth, the throat. Okay, in these the patients initially will have very low speech, and ultimately at the end they will not be able to speak. So they use some devices to communicate with the people, such as writing, communicating boards, or some speech generation devices, right? So ultimately they will have slowness of the speech because of the difficulty in articulation, and ultimately last they lead to loss of speech, means they won't speak anything. And if the patients with these, they can have difficulty swallowing, known as a dysphagia. Okay, but remember, in these patients they will have dysphagia for liquids also. Why? Because to propel the liquid fluid into the stomach through the esophagus, you need very good working oropharyngeal muscle control. In these patients, the oropharyngeal muscle control is lost. That's why they will have difficulty swallowing even for liquids. Whereas in a patients with a mechanical block in the esophagus, they will have difficulty swallowing the solid fluids rather than liquid fluids, right? And they can have drooling effect. Okay, the saliva comes over, and this is because of this dysphagia they will have what you call aspiration pneumonia, choking. Okay, so there are so many conditions. Remember, another one thing I want to talk about is the pseudobulbar symptoms. What are the pseudobulbar symptoms? In these, the patient will have consist of what we call exaggerated involuntary emotional response. Means they will laugh for 10 seconds, okay, and suddenly they cry. They start crying, okay. So you can see the changes in these symptoms, right? What you call episodes of intense laughter may be followed by immediately by the tears, right? So these are known as the pseudobulbar symptoms, right, guys? So let's talk about, as you know, we talked more about the clinical features of this disease. Another one important thing is what are the what you call the systems or systems spared, means they are never involved or not involved in ALS disease. Tell me, is remember for your assembly is remember extraocular muscle movements, okay, extraocular, that's the muscles of the eyes, okay, and the bowel and the bladder control, and another one important thing is they will have very good sensation since it's a motor involvement, so the sensation will be really good in these patients. Bowel and bladder is never involved, but it could be involved in the sense of like they will have what you call urinary incontinence, bowel incontinence, right? So but they are rarely involved, okay guys, right? And remember, and the patients who have what you call lower limb onset initially may complain of tripling, stumbling, awkwardness when running, okay, and foot drop is also seen, as I said, okay, and sometimes the patient can report it as a slapping gait, okay, guys. And if it has involved the upper limb, the what you call they will have reduced finger dexterity, cramping, stiffness, weakness, or wasting of intrinsic hand muscles, okay. And that's why, because of this involvement of the, because the small muscles of the hand are involved, they will have difficulty combing their hairs, they will have difficulty wearing the what you call shirts, buttoning the shirts, okay, writing, they will have difficulty in writing also, right, guys? So we talked about the more about the clinical features. So let's move on to the what you call, how do you diagnose this disease? It's all about, it takes a months to year to diagnose this disease, because initially they will not have all the signs and symptoms of the ALS. That's why the neurologist needs some what you call the more time, because he has to exclude the other conditions that mimic ALS, right? So we have different, it's a purely clinical history is the most important to diagnose this disease, clinical history, okay. Then we have what you call the EMS, then lastly we can take a biopsy, right, guys? So these are the important what you call investigations you can do to find out the exact cause of what you call the cause for this disease ALS, right? And there is also a criteria for that to diagnose ALS, that's known as a WFN, okay. I'm gonna talk about this criteria in next video, okay, because this is gonna be very lengthy. It's very simple. I'm gonna upload that video next later, okay. So regarding the treatment, as I said, the treatment for this disease, let me talk, not EMS, it's EMG, remember, okay. Regarding what you call the treatment, as I said, it's a supportive, you have to take care of their what you call supportive care, in the sense they have to prevent the choking, you have to prevent the aspiration pneumonia, you have to prevent them from having injuries, okay. So these are the supportive care you can give it. But there is some drug if you talk about, but that has extended the life of the patients with ALS, that's known as glutamate pathway antagonist, that's known as riluzole. So remember, this can be asked in examination. It extends the life of the patients with this disease, okay. And what are the important side effects of this what you call This drug is, they will have a stomach upset and a lack of energy. Okay, and we're going to talk about this in later regarding riluzole, very important topic also, right guys? So the prognosis, if you ask me about this disease, is the patient usually die within 2 to 5 years once diagnosed. Okay guys, so this was a biggest ice bucket challenge for you to read this video, to watch this video, right? So thank you so much for watching this video. I'm sure you're going out with some information about the ALS. If you have any new information on this, please do tell us through the comments so that we can keep ourselves updated. Thank you so much. Take care.